Hello everyone, this is Chadi Alraies from NCVH 2023. I'm really privileged today to be with Dr. Tom Davis, who's been an experienced interventional cardiologist and also peripheral endovascular interventionist. Dr. Davis, as you know, the challenging with severely calcified lesions above the knee and below the knee is it's a nightmare for all operators, and now we have, luckily, a lot of devices and options.
Yes.
So what's your algorithm and approach to these lesions?
Well, on peripheral devices for the calcium, my main thing is I use CSI, or now Abbott's orbital atherectomy. And really below the knee, probably more so than above the knee. I think for utilizing the atherectomy device below the knee where most calcified vessels are, and I think the modification that we get really does work a lot better.
Yeah.
What we're doing now is we have a different mechanism of doing it. I don't know if you heard the talk that was done yesterday on the toe technique, but what we do now is for this distal embolization, especially for orbital atherectomy, we cuff the distal vessel below where we're working, and then when we're done, we'll aspirate the debris out. And we've seen, that's I think the biggest angst for operators is the slow flow, or distal no flow, or even not even using those devices because of the flow aspects. But that we've really gotten to the point where we don't have that problem anymore.
All right. So in terms of complication of atherectomy devices and management, do you have enough option in our toolbox to manage them in OBL?
Oh, absolutely. You know, again, the beauty of the stuff that we're doing in the OBL, typically, as long as you're doing infrainguinal, even if you have a potentially catastrophic problem like a perforation or something like that, you can always put a cuff on there to improve flow, which is the nice aspect of that. And then, you know, we have covered stents, which are there. We have different types of snares that we can use if we have trapped things down there. So it's really a rare case that we have a complication that we have to send to the hospital.
No, and this is like sentinel events maybe once in a while.
Yeah.
In terms of atherectomy now, for above the knee femoral fempop lesions, orbital, rotational, or what you call panteris or
direction.
Yeah.
So my algorithm with that really is based on an ultrasound. I will do IVUS, and I think IVUS is really a key for peripheral interventions now. It's a rare case that you shouldn't do an IVUS on, I think now. Not only just for sizing, but you know, the composition of the plaque.
Understand with more info.
Exactly, morphology of everything that you're dealing with, and I think it gives you a better idea what device you can use, because we have a plethora of atherectomy devices or stents or covered stents, whatever, that we can use. And I think knowing what you have inside that vessel, especially calcium, can really give you a better idea on what device you're going to need to use.
Absolutely. It's interesting you mentioned that now, as you know, in the coronary space, everybody pushing to have more imaging done to understand it, but now you're already doing it in the peripheral, which is a big bonus for the patient and the procedure outcome.
Well, there's been a couple of position papers out there now on use of IVUS for peripheral vascular, and that's what I'm saying. You know, it's really beneficial for multiple reasons. And again, I think, if you're going to put in a stent per se, and if you have intraluminal calcium, you really have to prep that vessel better. Not just with doing angioplasty or what have you. Sometimes the calcium looks very significant on your angiogram, and you get in there and it's all deep wall calcium, and it's really not going to impede expansion. So I think that really does help tailor what you're going to do on a lot of things, especially I think above the knee.
Yeah. So I'm going to ask you a financial question. Is IVUS reimbursed in outpatient settings?
It is, for the most part. It's reimbursed in the outpatient setting. I think it's still reimburses more than the cost of the device still. I'm sure that's going to come down eventually. And it's not reimbursed in the hospital side of it as of yet either. But I think, it should. Hopefully that'll change.
Right. Yeah. I just want to mention that for the audience, like to understand that this shouldn't be a barrier not to use it. Is otherwise you get more information, as we mentioned, and help you prepare the lesion more and plan for the procedure.
Exactly. I think it's imperative.
Well, Dr. Davis, thank you so much for your time. Really appreciate your input and valuable experience.
My pleasure.
Please watch these videos and others on the NCVH YouTube channel. This is Chadi Alraies from New Orleans. Dr. Davis, thanks again.
You bet.
Thank you. Awesome. Thank you.